Hey everyone, let's jump right into it. Today we are taking a really rigorous deep dive into the complete clinical pathways for treating diabetes insipidus or DI. And I promise you, we are going line by line through the protocols. We're not skipping a single vital detail, so by the time we're done here, your concepts will be totally clear. Honestly, you won't even need to crack open the book to review this. So let's get started. Here's the clinical decision tree we're tackling today. First, conscious patients with intact thirst. Second, conscious patients with impaired thirst. Third, non-ambulatory and comatose care. Fourth, an overview of vasopressin analogs. And finally, exact dosing and action durations.
All right, part 1, conscious patients with intact thirst.
You know, it's actually pretty fascinating how our body's built-in alarms completely dictate our treatment approach here. If the DI is mild and the patient's thirst mechanism is working perfectly, the protocol is brilliantly simple. Just tell the patient to drink only when they feel thirsty. Their body is going to naturally keep up with the fluid losses, which prevents overhydration. In a normal system, that thirst trigger kicks in when serum osmolality gets above roughly 285 milliosmoles per kilogram. But contrast that with severe DI. In a really severe case, the patient literally cannot maintain adequate fluid intake, or they just can't tolerate the relentless, nonstop trips to the bathroom. At that point, behavioral instruction just doesn't cut it. Pharmacological intervention becomes an absolute must. So for those severe cases, we start with a vasopressin analog, specifically desmopressin or DDAVP. For the oral route, you're going to start at 0.1 milligrams twice a day and then titrate as needed based on their urine output. The typical range you'll see here is 0.1 to 0.8 milligrams a day given in divided doses. Now, if you're going with the nasal spray, the starting dose is 2.5 micrograms, which is 0.025 milliliters by nasal insufflation twice a day. You can actually titrate that spray all the way up to 20 micrograms twice a day as needed, but definitely keep in mind that the spray should be used for doses that are multiples of 10 micrograms.
But hey, desmopressin isn't the only tool in our toolkit. We also have alternative ADH-enhancing medications. There is a huge caveat here, though. These only work for chronic partial ADH deficiency. They literally will not do a thing if the patient has a total absence of ADH. The options here include clofebrate at 500 milligrams orally 4 times a day. Then there's clopropamide, which is cool because it actually increases the kidney's sensitivity to ADH. And finally, we have thiazide diuretics like hydrochlorothiazide. Now, I know what you're thinking. Using a diuretic to treat diabetes insipidus sounds totally backwards, right? But here's why it works. It depletes sodium, which ramps up reabsorption in the proximal tubules and shifts fluid right away from the distal tubules, which happens to be exactly where ADH does its job.
Moving on to part 2, conscious patients with impaired thirst. For this specific group, the clinical danger is immense. Because their thirst mechanism is completely offline, they are basically walking a clinical tightrope. They face a massive dual risk. On one side, severe dehydration, known as adipsic DI, because they simply don't feel the urge to drink when their body desperately needs it. But on the flip side, if they drink too much without that internal full signal, they risk dangerous fluid overload. Since their internal monitoring is broken, we have to step in and establish super strict external monitoring. Here is the exact management protocol. First, you absolutely must have the patient meticulously track their urine output and their daily weights, no guessing allowed. Second, you have to artificially balance their fluid intake and output using antidiuretic meds just to keep that urine output in a reasonable range. And third, you need to check serial labs about every single week. You are keeping a really close eye on serum sodium and BUN specifically to make sure they haven't drifted into dehydration or fluid overload.
Let's hit part 3, non-ambulatory and comatose care.
All right, now we're in critical care territory, and the monitoring gets incredibly rigorous. Step 1, you must follow their intake and output every single hour. Step 2, check their urine-specific gravity every 4 hours, and you also have to check it anytime their urine output spikes above 250 milliliters per hour. Step 3, you draw serum electrolytes with osmolarity every 6 hours. This constant, continuous data loop, it's absolutely non-negotiable if you want to keep the patient stable. So based on all that hourly data, we execute step 4, IV fluid management. Your base IV is going to be D5 half-normal saline plus 20 milliequivalents of potassium chloride per liter. You run that at an appropriate rate, usually around 75 to 100 milliliters per hour. Then you plus that base by replacing any urine output that exceeds that base IV rate, milliliter for milliliter, using half normal saline. But pay really close attention to this next point. For post-op patients who already received a ton of intraoperative fluids, they might just be going through an appropriate post-op diuresis. In that specific scenario, you only use half normal saline to replace about 2/3 of the urine output that exceeds the basal IV rate. But what happens if IV fluids alone just can't keep up? Like if their urine output pushes past 300 milliliters an hour? Well, then we move to step 5, which is pharmacological escalation. You've got 3 main options here. Option 1, 5 units of arginine vasopressin, that's aqueous pitressin, via IV push, IM, or sub-Q every 4 to 6 hours. Option 2, you can start a vasopressin IV drip, kicking off at 0.2 units per minute and titrating up to a max of 0.9 units per minute. Or option 3, a desmopressin injection, sub-Q or IV, titrated to their urine output. The standard adult dose there is 0.5 to 1 milliliter, which is 2 to 4 micrograms, given daily in 2 divided doses.
Part 4, Vasopressin Analogs Overview. Before we get into the weeds, let's establish the fundamental clinical difference between our 2 main players. DDAVP, which is desmopressin, is significantly more potent and noticeably longer acting than standard vasopressin. That's the baseline you need to remember. But before we dive into the exact numbers, I absolutely have to highlight this critical warning straight from the clinical source notes. Caution, sound-alikes. Sometimes Pitocin is confused with Pitressin because of similarities of the names. This is a classic, huge medication error risk that you just can't afford to miss. Pitocin is oxytocin, used in labor. Pitressin is vasopressin, used here for DI. Please do not mix these 2 up. Speaking of pitressin, there are a couple of strict contraindications you need to memorize. Because it's an aqueous solution of 8-arginine vasopressin, you have to use it with extreme caution in patients with vascular disease, especially anyone with coronary artery issues. Also, you should completely avoid the tannin oil suspension variant of this drug. Its absorption is erratic and its duration is highly variable, so it's just not reliable enough for clinical use. Let's break down the exact formulations and concentrations. For desmopressin given via sub-Q, IM, or IV, the concentration is 4 micrograms per milliliter. The desmopressin nasal spray is super concentrated at 100 micrograms per milliliter, with every single spray delivering exactly 10 micrograms. Desmopressin tablets come in 0.1 and 0.2 milligram sizes. And finally, arginine vasopressin, or aqueous pitressin, for sub-Q or IM use, is concentrated at 20 units per milliliter, which works out to 50 micrograms per milliliter. Finally, Part 5, Dosing and Action Durations. When we look at the injectable desmopressin routes, a beautifully clear pattern emerges. Watch what happens as you double the dose. The duration of action extends so predictably. A 0.5 microgram dose gives a mean duration of 8 hours. Double that to 1.0 microgram, you get 12 hours. Double it again to 2.0 micrograms, it's 16 hours. And a 4.0 microgram dose lasts for roughly 20 hours. The duration of action scales in this highly predictable, almost linear fashion, which makes it super easy to remember. Now, how does that stack up against the intranasal route and standard vasopressin? For intranasal desmopressin, a 10 microgram dose gives you about 12 hours of action. 15 micrograms gives you 16 hours, and 20 micrograms gives you 20 hours. But contrast that with standard arginine vasopressin injections at 5 units, which is 12.5 micrograms. Those only have a mean duration of action of 4 hours and can range anywhere from 4 to 8 hours. This proves exactly what we were talking about earlier. Standard vasopressin is significantly shorter acting than desmopressin. To wrap up our pharmacology deep dive, I've got 2 final essential clinical pearls for you. First, regarding the onset of antidiuretic action, for all of these preparations, you can expect them to start working about 30 to 45 minutes after administration. Second, here's a brilliant, highly practical cost-saving tip straight from the source notes. Giving just 1 microgram of desmopressin twice a day is just as clinically effective as giving a 4 microgram dose once daily, but it is obviously way less expensive for the patient and the healthcare system. We've covered a tremendous amount of ground today, exactly as promised, point by point, detail by detail, so you have everything you need without having to go dig through a textbook. Before we wrap up, I want to leave you with a thought to reflect on.
Ultimately, how does meticulous hourly monitoring of urine output serve as the absolute foundation for safely escalating every single one of these treatments? Whether you're managing a conscious patient adjusting their nasal spray at home or calculating complex IV replacements in an ICU, this entire decision tree relies entirely on strict observation of what the body is outputting. Thanks so much for joining me for this explainer. Stay curious, and I'll catch you next time.